students missed and so on. But as usual, we have some excellent grades and some not so excellent grades. So please, I implore you, because I've just been doing this a long time, if you didn't do well in the test, don't panic. Just do something to correct the issues. I say, get with a classmate who did well, or come see me and we can work on it. But you know, this is the routine from now on. Just every Monday, you're going to have a test, and sometimes you're going to have quizzes interspersed with that. So it just doesn't get any easier. And if you talk to your predecessors, this is the easy part. This is one of the easiest semesters for you. So, it doesn't get any. There's no let up. So you just need to psychologically prepare. All right. I'll stop preaching then. As I say, you should not be too concerned about these putative ethnic differences in the skeletal system. The problem is that with respect to the variability in humans in general, the inherent variability on virtually every cranial feature would be greater than any variation you would see in any ethnic things that you might encounter. So I don't know that while you often see slides and pictures of this sort, that you should invest very heavily into them. Often, however, genetic disorders will have manifestations in the skeletal system, and sometimes, as we pointed out before, in the pediatrics course, that can be confirmed in an initial pediatric assessment, craniometry. You do a morphometry assessment of the child in general, but there are a number of features that are associated with a lot of the more common genetic conditions. All right, so we talked a little bit about the bone. Let's move a little deeper into the cranium and talk a little bit about the meninges. So in this slide, we can see the laminar organization of our outer cranium. You can see the skin. There's actually another layer of connective tissue we'll talk about. In fact, we've already mentioned a little bit when we talked about the integument. But the outer layer is the skin. Then you have this aponeurosis. How do we define the aponeurosis? Yeah, the aponeurosis, unfortunately, doesn't have a very precise definition, but most of the time it's described as a flat sheet of connective tissue, and in most cases, it's a tendinous sheet. And that would certainly be true of the galea that you see here, the galea aponeurotica or the galea aponeurosis. This is a broad, flat, tendinous sheet between what is sometimes called the digastric muscle, the frontalis, portions of which you see here, frontalis, and then back here, the occipitalis. And so this is that broad, flat tendinous sheet that allows you to move your skull cap back and forth. Below that's the connective tissue. This is of the various layers of the scalp. This is the least tenuous. This is the least robust. This is generally, if there's a problem, if the scalp detaches from the skull, it's usually at this point, and that interior connective tissue. Then we come to the bone, and then immediately inside the cranial bone is that dura mater, the outermost layer of the three meninges. And under normal circumstances, in mammals, it should be tightly pressed up against the bone, and especially in the smaller mammals, it's very hard to separate them. In humans, especially humans with, I guess I'm looking for the word deceased, that tends not to be so much the case. And then interior to the dura mater is the arachnoid, and then deep to that would be the pia mater. So you have the three layers of the meninges listed here. We need to make several observations about the organization and structure of these. Dura, thick, adjacent to the skull, sometimes very difficult to deal with in surgical procedures. Now, as you look at the illustration over here, imagine the skull up, this is in German, but imagine the skull up here, and that dura is going to be pressed up tightly against the skull. And then notice the next layer has a rather interesting organization. It's called the arachnoid mater. Arachnophobia is what? Yeah, fear of spiders. No, I'm already exhausted. I've barely begun the day. But the reason I said fibers is because I was talking about spiders. I was thinking about a spider web this morning. I think because around my house I have lots of spider webs, and I was when I got out of the car this morning, I was covered. My head was covered in spider's web. Sometimes I just wake up covered in spider's web, but I think I got this one. I think I got this one walking around the house this morning, trying to see if any nefarious business had been going on. But I remember in southern Georgia, I don't know what kind of spider's web that was. I walked through, and that spider's web was like something out of a science fiction movie. It was actually smothering. It got onto a T-shirt I was wearing, and I washed that shirt, bleached it several times. That spider web never came off. It just chucked it. I'm not even, probably to this day the shirt's deteriorated, but that spider web is in some dump, perfectly functional. But in any case, that's why I kept saying fiber, because if you'll notice, this region of the meninges gets its name from the fact that there are spider web type processes extending down from the dura toward the surface of the brain. And so these are called arachnoid processes, sometimes called arachnoid trabecula. We've used that word before. And there are several things to keep in mind about this. Now, remember, the dura mater is pushed up against the skull. Here is the outer layer of the arachnoid. It normally should be pushing against the dura. So what is doing all this pushing? So make sure you understand that this volume in here is normally filled with cerebrospinal fluid. So the CSF, among its various other locations, is contained between this outer layer of the arachnoid and the pia mater, which is the sort of greenish region you see here. Yeah.
Is there any fluid between the arachnoid and the dura mater?
So the question was, is there fluid between the arachnoid and the dura mater? Under normal, sort of qualify this in two ways. Under normal circumstances, no. And in fact, we call this a potential space. What is a potential space? It's a space that, under normal conditions, is not patent, but if something goes wrong, such as some type of hematoma or bleeding, then that potential space becomes patent. So, number one, there should be no distance between these two. And again, if there is, then the potential space has become patent, and that's almost always a problem. Now, the only exception to that, so much of these courses, there are always little exceptions. The dura mater inside your skull is bilayer. There's two layers. So in reality, you're going to have an outer layer of dura mater, an interior layer of dura mater, then the arachnoid, then the CSF, and the pia. All right, there are places we're going to learn where the two layers of the dura mater separate, but that's normal. But otherwise, there should be no cavitation between those, any of this out here. The other thing you'll pay attention to, you'll notice in the arachnoid space, this region is sometimes called the arachnoid space. Notice it's heavily vascularized. Both cranial arteries and veins are present in here along with the CSF. And then you can see from this artery, there's an intruding artery into the neuropile or the parenchyma of the brain. And so the interiormost layer is the pia, and I think we mentioned this before, that pia actually follows the walls of the vessel into the interior of the brain. So it's a very delicate, very diaphanous tissue. Yeah.
So there's no periosteum on the deep side of cranium?
There would be. You mean out here is what you're talking about?
No, like on the inside. There's no periosteum per se between the scrotum and the brain.
Yes, but that's what I'm saying. The skull would be out here, right? That's what you mean?
Oh, right.
Yeah, there would be. That would be in in some respects similar to its appearance elsewhere. There are differences between, again, the flat bones and the long bones, but I don't need to get into them. With respect to the periosteum, we don't need to get into that. So does everybody have a fairly good idea of the general relationship? This is very, very important because it's going to help us understand how various pathological processes appear at the margin of the head. This is just to remind you that the meninges continue on down and encase or cloak the spinal cord as well. So the meninges not only encase the brain, they encase the spinal cord. CSF is bathing both. The only major difference, well, there's some other differences we'll talk about, but I guess the only major difference between the meninges of the brain and the meninges of the spinal cord is that at this point, the dura is just one layer. The dura is no longer bilayer, it's just one layer in the cord, around the cord. Otherwise, you still have the circulation of CSF, both just within the dura. And we'll talk about the flow of CSF. There's also CSF flowing through the interior of the spinal cord too, at least when you're young. Now we have numerous illustrations showing the same thing here. And if you don't like any of my illustrations, you can find some online that you like. But it's imperative that you understand the laminar organization of the skull as you see it here. This is just absolutely critical to an understanding of cranial anatomy. So we've talked about the scalp. You can see the scalp here. Here's the cranial bone. We've talked about the laminar organization of the cranial bone. Remember, we have the little compact bone, then we have the diploe, that's the cancellous bone you see in the interior. All right, so let's proceed. Here's the bone. Now we're moving into, you can see these two little white lines. Can you see them there? Two little white lines. There's one there and one there. That's the dura mater. The dura mater, so you can see there are two layers of dura mater for the most part, just inside the skull. Let's avoid this for a moment and come over here. So here are the two layers. All right, and then just interior, just deep to the interior layer of the dura mater, sometimes called the meningeal layer, is this black region here. Now what is that? That's the subarachnoid space. So make sure you understand that the dura, the subarachnoid space, you can see the blood vessels there. All right. And then that little white line, we'll just imagine that's the pia mater. So you really wouldn't see that anyway. So let's move back to the central region here. This sort of triangular spaced region that you see here. Now notice this is not, where my cursor is right there, that is not subarachnoid space. All right, that is not subarachnoid. Rather, that is where the two layers of the dura mater have separated. Anybody know what's in there? Blood, yeah, that's going to be filled with blood. Venous blood. So this is sometimes called the periosteal layer. This is sometimes called the meningeal layer. But you can see at this region right here, this is called the superior sagittal sinus. Superior sagittal sinus. I don't know if I have it written there anywhere. We can mention it here. It's certainly going to be elsewhere. I didn't spell that right. That's a T there. Sinus. Superior sagittal sinus. And this is going to be filled with blood in here, and that's what we call the sinus, just filled with blood. Now, again, formed from the separation of the two layers of the dura. So now notice what happens here. The meningeal layer right here, the two meningeal layers come together to form one layer again. And that is dura mater, just one layer that separates the two hemispheres of the brain. falx cerebri. Now we're not so, I'm mostly concerned now that you understand just this rather complex organizational scheme. Because these sheets and septi are very evident elsewhere in the slides. All right, so here's the superior sagittal sinus. Here's the falx cerebri, which is just one layer of dura mater. And so what is all this? What's this black area?
Subarachnoid.
Yeah, the subarachnoid space, which again is going to be filled with cerebrospinal fluid and blood vessels. And you can see, yeah.
So the falx cerebri, that one is made by the meningeal layer only?
You're talking about this layer, is this what you're talking about?
Yeah.
Yeah, that's just one layer of dura mater.
Well, which one? The meningeal?
It's going to be the convergence of the meningeal, but they just come together to form what histologists describe as one layer. And then, of course, deep to that is going to be the cortex of the brain, the gray matter of the brain, which you see here. And then what should be perhaps striking to you, if you've never noticed this, most of the interior volume of the brain is white matter. It's not the gray matter at all. Most of the interior of your cerebral hemispheres, your cerebrum, consists of wires, connections, which has an interesting name. If any of you are Twitter or Facebook enthusiast or whatever, if I asked you, oops, let me do this again. If I asked you what this word is or how to pronounce it, what would you do? Or how would you do it? Well, you folks are just too smart. I thought you were going to say connect to me, which is what you do on Facebook or Twitter. But you're right, that's the connectome. The connectome describes all of these complicated wires that go from one hemisphere, one side of the brain to the other, goes from the brain to the body and so on. They're trying to chart all this out now. Yeah.
Is there blood also in the inferior sagittal sinus?
Yes, thank you. Yeah, you're exactly right. So Louise is talking about the inferior sagittal sinus here. In just a moment, you're going to have to learn all the major sinuses, but I want to talk about the dura mater first. So let's make sure we understand the organization of the dura mater, and then we'll get to the sinuses. So that would be the superior sagittal sinus, and this would be the inferior. Yeah, and they just sort of run fore and aft in your cranium. As we age, this one sometimes disappears. I guess the only other thing, we'll introduce this now. This is, again, a large white matter structure. But below that, remember we said there is CSF in this region in here in the subarachnoid space. But these cavities here are also filled with CSF. Those are called the lateral ventricles of the cerebrum. And you can see there's some white matter separating what's called the septum pellucidum. So in these other illustrations, what I would expect you to be able to do, regardless of the illustration that I provide, you should be able to identify, and in your region, the layers of the dura. So for example, you can see the dura, you can see the bilayer here that it separates. This is the periosteal layer here. This is the meningeal layer. And then, deep to that would be what? The subarachnoid space, again, filled with CSF. You can see the trabecular processes or the arachnoid processes. That could be spiderweb-like. And then we have these curious things we need to talk about. These are called arachnoid villi. And their function, remember we saw those little depressions. We looked at one of the skull, the dry skull preparations earlier, and we saw some little pits in the interior of the calvarium. These things, as they move over to this direction, will actually extend up into the bone and cause those little pits we saw in the interior lining of the skull. But their job, the job of these structures, is to return the CSF to the venous blood. What we're going to find is there's a pressure gradient going like this. And so the CSF eventually is going to go back into the blood and eventually be resorbed. Yeah.
Are the trabeculae of the arachnoid layer, is that considered arachnoid layer or subarachnoid space or both?
I think probably the best descriptor would be the trabeculae are part of the subarachnoid space. I don't know how you could get away from that. So as I say, our burden here is to talk about the organization of the dura mater, and I want to continue that. But before doing that, once again, I just want to make sure you understand the hydraulic gradient here. I've said it several times, but normally the dura mater is pressed up against the skull, and the outer layer of the arachnoid is pressed against the dura. What makes all that possible, both in the brain case and in the spinal cord, this is true in the spinal cord as well, the hydraulic pressure inside the subarachnoid space. And so that has to be, that pressure has to be present in order for the meninges to do their job properly. So you can imagine, you're going to be involved in spinal tap procedure. You're going to be involved in patients who are losing CSF for one reason or another. Sometimes CSF actually leaks out of a patient's nose, for example. But you can imagine if that persists and there is insufficient compensation, that might have serious central consequences. All right. So, yeah.
For the pressure, is it the same inside the head as it is all throughout the spinal cord?
No, and there's a gradient, and that gradient, in part, helps to keep it circulating. And we'll talk a little bit more about that in just a moment. Basically, the pressure is greatest at the sites of CSF production, and then it will move away from that central region. All right, so here are listed some of the regions of the dura that you need to be able to identify, spell, pronounce, so on. So let's do that. So in this illustration, we're looking at both the dural membranes. We can see one here, for example. We can see one here. And then associated with those dural membranes are some of the venous sinuses. So for example, this would be the superior sagittal sinus here. That would be the inferior sagittal sinus there. We see part of it. I'm sorry, there's the inferior sagittal. That's a straight sinus. Here's the inferior sagittal sinus. So we'll go over the sinuses in just a moment, or some of these becomes complicated. Right now, what I want to direct your attention to is these membranes. So we've identified the falx cerebri. That's that little membrane in here that separates the two hemispheres of the brain.
Okay.
Down here is another portion that is at right angles, or more or less at right angles. This region right here is more or less perpendicular to the falx cerebri, and it's called the tentorium. Tentorium. So again, here's our falx. This is that falx cerebri. The tentorium is that. What they've done here, they've chopped off. This thing is going that way away from the sinus, but it's also coming toward us, and they've chopped it off there so we don't see it. But that's the tentorium. And does anybody remember what the tentorium separates? What regions of the brain? Yeah, the occipital cortex from the cerebellum. So the cerebellum is the inferior. And then there are a couple of others here we should be familiar with. We have, in addition to the falx cerebri, the falx cerebelli that simply divides the lobes of the cerebellum as it continues south. So falx cerebri, falx cerebelli, cerebelli tentorium. And several pictures, falx cerebri there. In both coronal and sagittal perspective. You can see the tentorium over here. Here's the falx cerebelli. The falx just means crescent shaped. And then the cerebellum, the cerebri, sometimes called the cerebral falx.
Would you say those separated out?
The falx cerebri separates the two hemispheres of the brain. The falx cerebelli separates lobes of the cerebellum. And then the tentorium separates the occipital cortex from the cerebellum. You have a better illustration of the tentorium here and the falx cerebelli there. And the other feature we should mention at this point is something called the tentorial notch, which is this opening in the middle here to accommodate the brainstem. That's called the tentorial notch. This is a little bit grisly, but as you look at this, you can see the scalp reflected here. You'd expect to see these are portions of the tentorium that you see with the arrows. And then remember, as we talk about these osteal systems, the tentorium, the dura is really encasing the entire calvarium and also the basic cranium. So we're looking at the dura mater that's overlying tissue here. This would be the tentorium portion there. All of this would be dura mater. The only other one we haven't mentioned here is this little creature down here. Now, this should look relatively familiar to you. You should be able to identify all the structures here. You know that at that point we're looking at the sphenoid bone. Excuse me, I'm having computer issues here. Computer is suddenly no longer responsive. So I'll do the best I can. It writes, but it doesn't erase. Oh, so this is the sphenoid here. Of course, we have the Turkish saddle here. Here is the pituitary gland. And so all of this is going to be dura mater. But you'll notice in this region, the dura mater flattens out as it approaches the pituitary gland, the Turkish saddle. Let me see if I can find a way to. There we go. Part of it's working, part of it's not. So right in here, where this dura mater, you can sort of see it here and here, where the dura mater surrounds the pituitary stalk, a little plate is formed, and that's called the diaphragma ocelli. That's just a part of the dura mater. Now, histologists differ on this, but we're going to make it simple, and I think Ackland does the same thing. We're going to say that the Turkish saddle, this bone is the Turkish saddle, but that whole space is encased by dura mater. But the flat portion up here, that's the diaphragm that you will see referenced. And you can see then the pituitary stalk, which is this structure, is completely encased by dura mater. So in an illustration like this, you should be able to identify the falx, you should be able to identify the two falx or every falx cerebelli, you should be able to identify, for example, what portion of the tentorium you can see there. And then you can see what we were just talking about here, the diaphragm ocelli in this region right in here. So my core computer is just dreadfully confused. Now what we're looking at here are the meningeal arteries. Again, the meningeal artery is a little bit odd because the common carotid is going to come up the neck about C4, so it's going to branch into an internal and external carotid. What we're looking at here is the external carotid. And you can see some of the major branches of the external carotid, the facial artery, the maxillary. And in fact, this middle meningeal artery is a branch of the maxillary, which in turn is a branch of the external carotid. But here's what's a little odd about this arrangement, is that normally the external carotid perfuses the structures of the scalp, the extradural structures, the structures outside the skull, in fact. But the middle meningeal artery is in this curious space between the dura mater and the skull. In fact, in some anatomical literature, you will see written that the middle meningeal artery is part of the dura. I'm not sure I want to get into that battle. But in any case, all of this reticulation that you see here, these are branches of the middle meningeal. There's an anterior meningeal over here and a posterior meningeal here, but it's this one, and you can see the foramen spinosum there. It's this one that runs adjacent to the pterium, the middle meningeal artery. Yes.
Did you say the middle meningeal arteries in between the dura?
I think that's the best way to think of it. Remember, we've seen several pictures of, the question was, where is the middle meningeal? And I think it's probably best or most accurate to characterize it as being between the skull and the dura mater. We've looked at several illustrations where we could actually see like the little rivers in the skull to accommodate it. So I think that's the best way to think about it. Some of the illustrations and some of the gross anatomical preps that you will look at, it will seem as if the middle meningeal is actually embedded within the dura. That's what I can tell you in terms of, and in fact, if you look at the anatomical literature, there's not a consistent opinion on that point. We've indicated that it enters the middle cranium fossa via the foramen spinosum, and the middle meningeal actually has its own branches. I'm not too concerned about you sorting all that out, but just note again, it's this region right here that is most vulnerable to skull trauma. We can see the middle meningeal vein accompanying the artery, pretty much along the same pattern. And then this is just what I was talking about. The green here is actually within the brain cave. I'm sorry, actually within the skull cap, and you can see the little river valleys that are induced developmentally by the reticulation of the middle meningeal in the skull. So we had the video earlier of the violin player and the guitar player doing their thing while in brain surgery, undergoing brain surgery. So what would be the implication of that? Why wouldn't this be agonizingly painful to have your brain operated on and then you'd be awake?
Any nervous tissue.
I'm sorry?
Any nervous tissue. No nerve ending in the dark.
Yeah. Any way that we approach the topic of pain, it's going to make your head hurt. In the sense that pain is at least this type of pain, the pain we're talking about is dependent upon pain receptors, nociceptors. And as you can see, as the slide points out here, they're present in the dura mater, less so elsewhere. They're certainly not present in the interior of the brain, in the neural pile, the gray matter or the white matter. And yet, can you have pain with nociceptors and no brain? No. So it's just very curious that on the one hand, that the brain feels no pain, and yet the brain is responsible for pain. Right? This doesn't concern you. I find it philosophically very troubling. In any case, make sure you appreciate that it's only the dura that has the extensive innervation of nociceptors. And these are, that we talked about, the cranial nerve 5 being the DRG. A lot of those nociceptors report directly to the DRG, the dorsal root ganglion of the brain. I should say, I'm so used to saying that. The trigeminal ganglion, the semilunar ganglion, which is the ganglion for cranial nerve 5. Now, it also says here that these nociceptors also are afferent to the first, second, and sometimes third cervical nerves. And the cervical nerves, and we talked on the back of these are somatosensory nerves, and these are part of what we call the cervical plexus. The first 4 peripheral nerves of the spinal cord, first 4 cranial nerves make up the cervical plexus. So you have sort of a dual innervation here, both the cranial nerve 5 and the cervical plexus. We've already defined the term potential space. It's terribly relevant in this context because under normal circumstances, the dura should be tightly apposed to the skull, and the outer layer of the arachnoid should be tightly apposed to the dura. And so anytime that is not true, the potential spaces become patent or real, and that's almost always an indication of a problem, either bleeding or some type of CSF irregularity or compression, neural compression, or some other cause. As you look at an illustration like this, then I would expect you with labels removed to be able to identify, for example, the arteries and veins that reside within the diflow of the skull. We call these difloic vessels. So here's the diflow here, and you can see all of these vessels, then you see them chiefly venous in this illustration, run within the diflow. And you can see in something like this, we have a pathway from outside, from the scalp, outside the skull, to the interior of the brain. Anytime you see this, this is called an emissary vessel. An emissary vessel, they're almost always venous, but they are potential routes of infection, a mechanism or a path by which infection could move from the outside of the body to the interior of the brain base. Otherwise, you see the 2 layers of the dura here. You see the separation of the dura, the periosteal and meningeal layers. You see the subarachnoid space, the falx rubber, and so on. So be able to identify all of these, even in this complex sort of 3-dimensional coronal section. And these are the arachnoid villi. And you can see the arachnoid villus over here is actually intruded into the plane of the skull, causing one of those foveolae, arachnoid foveolae, or indentations in the skull. Remember, the function of these is to return the CSF back to the blood. I don't think there's anything here we haven't talked about, but what Luis was asking a question earlier about the pressure gradient. And so what is going to generally be the case, and I don't know that I have a good picture here. We can start with this one. The CSF is a filtrate of the blood. The cerebrospinal fluid is formed from the blood in various regions. For example, in the floor of the ventricles, and you can see in the 4th ventricle here. The red region is something called the choroid plexus. Choroid plexus. frustrating with this computer right now. But the choroid plexus is going to generate, you can see it right here. There it is, some here. It's going to produce the CSF from the blood. There'll be a favorable pressure gradient, hydraulic pressure gradient from the ventricles. And you can sort of see the direction of flow here because there's going to be a low pressure region up there at the arachnoid villi, and that sort of maintains under normal circumstances the movement of CSF from the choroid to the arachnoid.
Do all four ventricles contain that choroid plexus?
Yes and no. So implied in your question, for everybody's benefit, Bob mentioned 4 ventricles. There are 2, we'll talk about these in just a moment. There are 2 lateral ventricles. I made the mistake of hooking up the mouse today. That's the problem. So here are the 2 lateral ventricles here, and they have this sort of C-shaped appearance. There's an anterior horn up here and a posterior horns back here. And then here's the 3rd ventricle, and it's just very, very thin. Just ridiculously thin right in here. When I say thin, there's just not much volume to it. It's just sort of 2 layers of this. And then the 4th ventricle is right down here. It's sort of at the mouth of the cerebellum. Now, to get back to your question, it's highly variable, but in general, what you find is that there's choroid along the floors of the lateral ventricles. It is not very abundant in the 3rd ventricle, and then you see an efflorescence of it again down here in the 4th ventricle. It's fairly evident there as well. But really what's happening, as you can see, fluid is residing within the lateral ventricles. There are just several small communication points between the lateral and the 3rd ventricle, and then this pathway takes it along the spinal cord, through the 4th ventricle and along back through the spinal cord. Now, it's a little more complicated than that, at least the trajectory, for a couple of reasons. First of all, there's also a path for the CSF in the spinal cord. You know, you have your gray matter and your white matter, and you have the 2 little butterfly wings. And right in the center, there's a little connecting stretch of gray matter. There's a little opening in there called the central canal through which the CSF can flow. And then the other complication that we need to mention, I guess, in this context, is that, I don't know if it's mentioned here or not. Sure it will be. Well, here's a nice illustration. You have what are called ependymal cells. We'll talk about these this afternoon. Ependymal cells. And there are ependymal cells lining most of the arachnoid, especially. When I say arachnoid, I mean the region around the, let me make that clear because that's not, we're looking at the whole thing here. There are ependymal cells lining the ventricles. There are ependymal cells lining the central canal I was just talking about. And they're very specialized glial cells that help to regulate CSF volume as well. So you have a number of ways that the CSF pressure, production, and reuptake can be regulated. And these specialized glial cells seem to contribute to that by virtue of their special properties. We'll talk about this afternoon. So, again, here are 2 lateral ventricles, ventricles 1 and 2, don't know which is which, 2 lateral ventricles, 1 and 2. You can see the choroid here. Choroid is taking the blood and generating CSF, sort of a clear type of filtrate from that. More choroid down here as well. And then what are these little things right here? What are they? Those are the arachnoid villi. So again, the idea is the CSF is being generated here, it's going to circulate around the entire CNS according to relative pressure gradient, and eventually be returned. You can see the return pressure gradient here in the subarachnoid space back to the arachnoid villi, here they're calling them granulations, where the CSF is then returned to the venous blood. So are there any questions about what's generally happening here, and just be able to identify the components of this cerebrospinal fluid system? You have several illustrations showing the same thing. You show the relative abundance of the choroid, and then they're showing you how the how the CSF is returned to the venous blood in the superior sagittal sinus by the arachnoid villi. And then you can see them here as well. I have a number of things we've talked about. So in an illustration like this, you should be able to identify the bulk cerebri, the subarachnoid space, the periosteal dura, the meningeal dura. You should be able to identify a nice little emissary vein. And we talked about the emissary veins that pass through the skull, providing a mechanism whereby outside infective agents can make their way into the brain. Here we're peering into a superior sagittal sinus, and you can see some of the arachnoid villi look like little grape clusters in there. See the middle meningeal artery there. Dura mater reflected back. All right. I think because it's going to be a long day, we'll stop there, and so I'll see you this afternoon for physiology.